Hello all, and welcome to the Caregiver Support Series.
Hey everyone, did you learn something new from last week's episode? I hope you're able to share what you learn with the people that you love. Today, I'm going to continue to bust the myths of hospice. Last week, I went through the first 5 of the top myths, so today I'm going to finish out with the last 5. Please sit back with your favorite hot beverage. I guess it should be cold now. And as always, feel free to reach out with questions or topic requests. Words to describe is going to surround myths number 6, 7, and 8 on my list. The education corner is dedicated to myth number 9 and related to a topic that should sound familiar. You will find additional related content at the end of the episode. And next week's topic is palliative care. We also will have our second guest speaker, Katie Williford. She is the Vice President of Business Development for both Hospice of Northwest Ohio and Sincera Palliative Care. Katie is a fabulous speaker, and I know you will enjoy hearing what she has to say. Myth number 6. You need a physician referral to come on a hospice program. The truth is, you do not need a physician referral to come on a hospice program. In fact, a lot of our requests for admission appointments come from previous families that we've served. They come from other physician offices and hospitals as well, but it's not necessary. In fact, sometimes we assist with reaching out to someone's physician to inform them that their patient is seeking hospice. At that point, it's up to the patient and family, as well as the physician, to decide if that physician will continue as the patient's attending and oversee their care, or if they want Hospice of Northwest Ohio's physicians to take the lead. Some community doctors prefer more of a consultative service, so they continue with routine care, but let our physicians do the orders for symptom management. I talked a little bit about admission criteria for hospice in the last episode and included some related content there too. Myth number 7. Once you sign on, hospice won't treat anything or takes your medications away. This couldn't be further from the truth. Once you understand the history of the hospice movement, you'll have a better idea of the hospice philosophy. Hospice uses individualized care plans based on a patient's personal goals of care that include all different kinds of medications, therapies, both preventative and interdisciplinary. The goal is to assist someone in living as well as possible, as long as possible. I was at a library not too long ago, and when I asked the audience what some of the things they've heard about hospice, someone raised their hand and said they heard once you're on hospice, you can't eat or drink. It kind of took me by surprise, but of course I explained that we want people to eat and drink. We want them to have meals with their families and friends. Sometimes we actually give patients medications or ideas on how to stimulate their appetite. A lot of people also don't know that we pay for medications that are related to the patient's terminal diagnosis and to their comfort. We also pay for medical equipment like hospital beds, bedside commodes, or wheelchairs. We'll pay for treatments and therapies that are all related to comfort or the terminal diagnosis. So I'll give you an example. Let's say someone comes on the program with end-stage COPD, which is a lung disease. We would pay for anything related to the COPD, like breathing treatments, steroids, anti-anxiety meds, opioids, whatever's needed to help control those symptoms related to COPD. An example of what we wouldn't pay for that patient would be if they had thyroid disease and needed to take Synthroid. But that doesn't mean that we stop them from taking it. And myth number 8. Once you sign on, you're stuck. You can't change your mind, you can't go to the hospital, etc., etc. Again, that couldn't be further from the truth. A person is always able to change their mind. All it takes is a signature. If a new treatment becomes available that a patient would like to try, they just revoke the hospice benefit and we wish them the best. Again, our goal is for people to live as well as possible, as long as possible, and to fulfill whatever goals they may have. Believe it or not, there are times when a patient ends up getting better after being admitted to a hospice program. An example I can think of would be an Alzheimer's patient who has a short-term UTI. They can look really, really sick. They're admitted to the program, but continue with the antibiotics. They may end up returning to their baseline status. This type of patient may graduate from the program and actually come off of hospice. I've seen it with heart failure patients too. Once they're on the program and their symptoms are managed, they tend to start doing better with having more quality of life, and sometimes they just don't qualify for certification anymore. We love those types of stories. When a patient is on a hospice program, they have to be certified and recertified about every 2 months. There are agencies who are responsible for auditing hospice programs so they are not fraudulently admitting patients. We have to prove that a patient remains appropriate for the program, and sometimes that means documenting things like weight loss, increasing hours of sleep, more shortness of breath, or less ability to care for themselves. Because we don't have a crystal ball, we can't pinpoint exactly when someone will die. Is it 2 months after being admitted? 8 months? A year and a half? In the meantime, we want to work with the patient and their caregivers and families to support whatever it is the patient wants to do. And if that means revoking from hospice and going back to treatment, we support that too. Can you tell this is a hot button topic for me? Myth number 9, hospice hastens death using medications like opioids. No matter what way I hear it, it breaks my heart. In one way, I can understand that when patients come on the program very late in their journey, they're already symptomatic, close to actively dying, so they may be started on medications to help control their pain, shortness of breath, or anxiety, whatever it is, and then they seem to die quickly. I get it. But they were going to die either way, and in most cases, we're at least able to provide some symptom relief for them. And in almost all cases, we can provide support services to the family who is left to grieve. The goals of the interventions used at the end of life are to provide symptom relief, but allow the body to die naturally. And that journey and timeline is unique for everyone, as you can imagine. Myth number 10. Palliative care is the same thing as hospice. Palliative care is not hospice, but hospice is palliative care. My nurse tip for the week will give you an easy way to explain the difference to people. Palliative care is a holistic philosophy for anyone who is ill, regardless of age, diagnosis, or especially prognosis. The biggest difference between the two programs is that when a patient is on a palliative care program, they can still be seeking curative treatment. Once someone opts to elect their hospice benefit, they can still receive treatment for any symptoms, but they can no longer be pursuing curative treatment. But remember, if they decide they no longer want to keep their hospice benefit and want to go back to pursuing curative treatment, they are free to do so. Thanks for watching. This has been an episode of the Caregiver Support Series brought to you by Hospice of Northwest Ohio. Next week's topic is palliative care.